Thank you very much.
So the presentation is on spotlight on mitral annular calcification. This term brought into my attention by one of my colleagues. He's a senior colleague of mine back in Bahrain before I start my residency program. And it was a few years back. People were not talking a lot about it. And we just like he was discussing and explaining to me the disease and all, which is a different entity from the rheumatic heart disease. In my country, there are patients with rheumatic heart disease. It's less now with the younger generation, but the older generation who didn't have much, like 40, 50 years back, didn't have much access to healthcare. They came with we ended up having a lot of patients with rheumatic heart disease, but he came into he brought to my attention that there is another entity what's called mitral annular calcification, and we have to make sure that the difference between the two entities. Mitral annular calcification is defined as calcium deposition in the fibrous skeleton of the mitral valve. Mostly, we see patients incidental finding during coronary angiogram or doing an echo for another indication, and we found out just there is a calcium in the posterior leaflet or on the posterior annular aspect of the mitral valve. The question, does it carry any poor cardiovascular outcome? Is it benign? So all those questions brought into attention by the doctors. Those are CT images of the mitral annular calcification. We can see the calcium deposition clearly here, and this is a mild mitral annular calcification on CT scan pre-TAVI. So for the epidemiology, we can count that 8 to 15% of the population have mitral annular calcification. Another study stated 8 to 27%. Most of the patients are elderly. We're talking about 70, 75 and older. But the presence of mitral annular calcification doesn't mean that we have a mitral valve dysfunction. And this is an important term, the mitral valve dysfunction, which reflects the disease itself when the patient develops an abnormality at the level of the valves, and that needs some either medical intervention, medical treatment, surgical intervention, or percutaneous intervention. This is a study. This is a landmark study done by the team of Mayo Clinic. Dr. Guerrero has a lot of activities in the mitral annular calcification and its intervention. What they did is, it's a very interesting study. What they did is they studied all comers, 24,000 echoes were reviewed. All these echoes were the first echo done for the patient. And they wanted to know the prevalence of the mitral annular calcification, and they followed the patient over the course of 3 years. And what they found out that most of the young patients, you have a low percentage of mitral annular calcification here. The MAC, they call it MAC, 1.8%. While older patients, let's take here, 33% of them, 70 to 79 years old, would have MAC. More than 80 years old, expect that you have 50% risk of having MAC, and so on. Does it carry any risk? Yes. So during the mean follow-up, they found out that having MAC with mitral valve dysfunction carries mortality, while having MAC without mitral valve dysfunction itself carries some mortality risk. And if you don't have either MAC or mitral valve dysfunction, the risk is less. What's worth noting, and it was noted by the team who did the study, is that a lot of the patients with mitral annular calcification or MAC have other entities of valvular disease, and they focused on aortic stenosis. So here in patients with aortic stenosis, they would have another structural problem. We're talking about 27% of them were having an aortic stenosis. The association between MAC and aortic stenosis was high, and a lot of the literature focused on this entity. But the course of the progression of the disease is different. It's totally different. So this is a case, enough of the theory. 71 years old male with past history of diabetes, hypertension, dyslipidemia. He was obese. He had some sort of chronic disease. His cath was normal, carotids were normal as well. So in 2017, this was the first echo. Ejection fraction was 55, aortic valve not severe, and they didn't comment a lot on the mitral valve. In 2022, ejection fraction was precisely 66, and we have a severe aortic stenosis. The quality of the study is bad. Sorry for that. I think because of the obesity, we can see here there is some sort of a calcification with restriction of the aortic valve opening, and we can see the mitral valve here. This is a parasternal long axis view of the aortic of the heart. This is the mitral valve. This is left ventricle, the right ventricle over here. The aorta turns out to be here, and the left atrium is here. And here we can see, and this is the posterior leaflet, this is the anterior leaflet that moves very fast. The posterior leaflet is kind of restricted. It's not very obvious here. And there is some sort of calcification just before the leaflet. Unfortunately, in 2022, it's not very clear because of the poor image quality. Again, we can see some sort of calcification here. This is part of the aortic valve. This is an apical view of the four-chamber apical view. This is the left ventricle, right ventricle, the left atrium, and the right atrium. Mitral valve, tricuspid valve. If you just take the probe, go down with it, you can open up the five-chamber view and see the aortic valve, where we can see it a little bit here. This is a two-chamber view of the heart, left ventricle, left atrium, and we can focus on the mitral valve. You can see some sort of calcification, and the valve leaflets are not healthy. The calcification more or less are the same here. Some sort of cordial calcification, you can see it after 5 years. The point here is that we can see the stability of the mitral valve calcification over 5 years, while the aortic stenosis had progressed. It's a total different entity, totally different diseases. In 2017, we have a gradient that's less than 5, or after 5 years, again, the gradient is less than 5. No mitral regurgitation. The CT scan after 5 years, you can see some sort of calcification here. That's the mitral annular calcification, mitral valve, and the right side of the heart. Here, this five-chamber view with the aortic valve calcification. So just we're gonna shed light on pathophysiology. What's the mitral annular calcification? Some surgeons deal a lot with it before the percutaneous interventions were developed. So when the patient comes with mitral valvular dysfunction, they tend to debulk the annular calcification, and what comes out is some sort of things like that. And they studied it. It's actually it's kind of a ponification, and some of the surgeons call it ponification rather than calcification, like a bone. And they furtherly studied it, and they found out that those are small molecular studies, and where they found out that there is osteocalcin, which is a hormone that helps with the osteogenic differentiation, and it has to do with the osteoblast-derived ossification and calcification. So there were some sort of hypothesis that the calcification itself, it reflects the stress and the strain on the mitral valve that results in on the long term in the calcification for various reasons. Some had to do directly in relation to the structural changes over the years with the advanced age, and some other metabolic factors. Going to back to our talk, the difference between rheumatic and MAC-related valve dysfunction. Rheumatic mitral valve disease, usually you have a commissural effusion. It's a funnel-shaped geometry. Usually we found it in a younger population. And we have a lot of studies in this population, and the mitral valve area quantification is validated. And usually you can go with a percutaneous balloon valvuloplasty. While the macrolated mitral valve dysfunction, the commissure are spared. You have an open commissures. We can see them clearly here. This is a 3D of the echo. The two commissures are open. Here are fused. That's why the balloon valvuloplasty works well with the rheumatic mitral valve disease, while with the MAC usually doesn't work. Usually we have elderly patient, and the mitral valve area quantification is very, very challenging. And challenging because you have other valvular heart disease, you have structural changes, and it's not validated yet. So you have two entities of mitral valve dysfunction. You have the MAC-related mitral stenosis and MAC-related mitral regurgitation. Regarding the MAC-related regurgitation, mostly the mechanism is leaflet extension. So the calcification that will extend to the leaflet, which leads to restriction and malcoaptation and MR. What happens is that the calcification starts in the annular part, and it will grows toward the distal part of the leaflet. And this will cause disruption of the closure and opening of the valve, and which will lead eventually to mitral regurgitation. Another mechanism is the extension of the mitral annular calcification. We can notice that the calcification starts in the annulus, but it goes into the myocardium and into the leaflet, and this will push up the leaflet, and it will cause a malcoaptation, which leads to MR. And the cordial calcification, which lead to the loss of elasticity of the cordia, and eventually MR. Again, the MS is a kind of different entity here. The restriction of the valve movement, leaflets movement, mostly in diastolic flow, which leads to MS, and leaflet calcification that the leaflet extension calcification, which will restrict the movement. Here we can see this is a rheumatic, and you can see the fusion. Well, this is an mitral annular calcification. The commissures are spared. In 2022, I guess, this was published. So there were two main classification. Alid had a simple classification where he had grade 1 to 3, mild, moderate, severe. If the classification of the annulus is less than 180 degree, it's mild. Less than 270 is moderate. More than 270 is severe. He added some other stuff like extra-annular calcification, whether it's the annular or anterior leaflet, whether there is an extension to the myocardium or the papillary cells. So it's a bit of a simple classification. You can do it even if you are in the emergency. You can just it's a grade 3, grade 2, based on scoping the echo. Here, a little bit detailed, where he integrated also the team integrated also the calcium score, and they had 4 grades. What Churchill tried to do is to fusion the two together and made it kind of simple: mild, moderate, severe. So we're trying to make things simpler to classify patients, and this will help us to follow up patient, and will help us to decide whether to address the patient for a team who deal with such diseases. Quantification of the mitral valve area is very challenging. So to measure the mitral valve area, usually what we do is a lot of echocardiographers, what they do is planimetry. So they will go to the short axis view of the parasternal short axis view, and in the diastole they will measure the area, the opening area, And if it's less than 1.5, they will consider it as significant. This is a 3D. It's a good method. The problem is the availability of the technology. And the other problem is the quality. It has to be a good quality. Here again, for the 2D planimetry, again, it has to be a very good quality to count on it. Other very fast way to do it is the pressure half time. So imagine we put the prop in the mitral inflow, and we did a continuous Doppler. And based on the continuous Doppler, it will measure the velocity of the blood velocity, and we will have this some sort of graph in the echo. So based on the pressure half time, based on the how much time does the pressure or the velocity takes to go from the left atrium to the left ventricle, we can calculate the mitral valve area based on calculation. It's very good. It's easy to be done, but patient has to have a good compliance. If you have decreased compliance, like in diastolic heart disease, diastolic dysfunction, in patient who are hypertensive, aortic stenosis, any problem that can cause diastolic dysfunction, we cannot count a lot on the pressure half time. The continuity equation, one of the best and one of the accurate measurements. Again, it's based on an equation. And the theory behind the continuity equation is that the flow that comes from the right ventricle. So imagine that the blood comes back to the right the right atrium, goes to the right ventricle, exits the heart, goes to the lungs, comes back to the left atrium, to the left ventricle, again exit the heart with the oxygenated blood. So all this flow, usually, the theory is it will be constant, whether it's the speed or the volume. So based on that, they were able to calculate the mitral valve area, predict the mitral valve area. We use the same continuity equation in the aortic valve disease also. The limitation here, if the volume is disrupted, and like an MR or AR, or sometimes in atrial fibrillation, patients will be challenging to use this. So again, so you cannot rely on only one method to measure the mitral valve area here, especially in MAC. So what we do usually is we do the three. And nowadays we have easy access to CT scans, so they do it with CT scan as well. It's very complicated. So it's kind of headache what I was explaining here. So most of the people will say the same thing. So there was a team, Bertrand and the team, they tried to do things simpler. So what they did is that they took the patient, they will do a continuous Doppler across the mitral valve. You will have a gradient. So this is the mean pressure gradient. So after you put the continuous Doppler, you'll get the mean pressure gradient. If it's 3 to 5, it's mild. 5 to 10 is moderate, and more than 10 is severe. So they took those patients and they wanted to know, does it carry any cardiovascular risk? Does it carry any mortality? They adjusted this for age, sex, hypertension, diabetes, and coronary disease, and chronic kidney disease. So what they found out is that there is an independent risk for the mean transmitral pressure gradient. If you don't have any grade in the control group, you have good outcome. If you have severe, which is more than 10, over 10 years, you have more risk. And we can see all the graphs are separating early. So this is a good method in following the patient, and it's an argument for thinking about treating such patients and not leaving them just in the forest. A lot of theory. Go back to a case, 81 years old, hypertensive, dyslipidemic. He has aortic stenosis, and we know that patients with aortic stenosis, they tend to have other valvular heart disease, mostly related to the heart skeleton. We're talking about here mitral annular calcification. he had a normal kidney clearance. The angiogram is normal, and this is the echo. So this is the, again, poor quality, sorry for that. This is the parasternal long axis, left ventricle, right ventricle, aortic valve, aorta that goes up here, and left atrium, and the mitral valve goes just here. And we can see there is some sort of radioepic image that's moving. That's the mitral valve, heavily calcified. Here we can see clearly that the chunk of the calcium. This is a zoom in video on the calcium. You can see it extending to the leaflet, restricting the posterior leaflet. It's not moving, going into the myocardium. And the anterior leaflet is fairly spared with some sort of calcification in the skeleton here. This is a the fourth chamber apical view. There is some sort of hypertrophy. It's not a normal myocardium. Maybe he carries some sort of amyloidosis or something like that. This was not studied. We can see this is the tricuspid valve with the tricuspid regurgitation. There is no MR, but we can see some sort of reverse PISA, and this is signifies the acceleration of the flow in the mitral valve. This is a two-chamber view. You can see the calcium. Again, up, but again, going back to the Doppler, apart from all the calcification, apart from all the flow acceleration, we still have three gradients. So it's really difficult to have a severe mitral annular calcification. Most of the patients are with mild or moderate mitral valve dysfunction. This is another guy with the same thing, mitral annular calcification. You can see the calcium clearly here. Normal angiogram. And this is the CT pre-TAVI, and you can see the calcium just in the posterior annulus. So after that, what's the treatment? So three options: medical treatment, surgery, or percutaneous treatment. Before proposing the treatment, we have to know who should we treat. So there are three groups based on the, again, Churchill in 2022, a very good paper. It summarized it all. So he categorized the patients into three: either stenosis with a 1.5 centimeter cubic or regurgitation with them where he has the patient who should be having more than moderate MR, and mixed valve where the gradient is more than 8 or 10. What can we propose for them? If he's symptomatic, if there is no symptoms, nothing. You just follow them up with echo. If there are symptoms, we treat them like heart failure, preserved ejection fraction, diuretics, rate control. You have to follow them up with an echo as well. If the symptoms persist, you have to refer them to a team where they deal a lot of this, and based on the assessment, either will be percutaneous intervention or a very challenging surgical repair. And how can we decide? This is based on the anatomy. So if the anatomy is suitable for surgical repair, which is very challenging and such, because all the architecture and all the anatomy is disrupted by the calcium. So for the surgeon to repair it, it will be very challenging. They do a debulking. Sometimes they leave it alone after the debulking if there is no stenosis or regurgitation. And what they do is, after the debulking, I've assisted one case. We tend to have an transesophageal echo, and we just like measure everything before the closure, and they decide. But mostly what they do is they try to place a ring in place. Rarely they can put a valve. Other alternatives are percutaneous valve implantation. For the percutaneous valve implantation, it depends all on the planning the case. So the planning, usually most of the teams, they work with 3 mensio. it's a software where we can upload your CT scan, and then you can just say it's kind of automated. So we can see here the calcium. This is short view. This is a cylindrical geometry that mimicking the valve, and we put it to understand how it will behave, and to choose the size. Um, so planning is, it's all about planning for percutaneous. Some teams, I met a team from Madrid where they use 3D printing. And the advantage of the 3D printing is that you will understand again more how the valve will behave after implantation. Here, for example, after implanting a Sapien 3 valve, this is a TAVI valve, but they used it in the you can use it for the mitral valve. You can see that the LV outflow tract will be obstructed by the anterior leaflet. You can do a resection with certain devices like lampoon and else, and then you resolve the problem. Here, you can see after implanting the valve, you would have a paravalvular leak. You can treat that percutaneously with a plug. So, for example, you're going with the case with a plan. You know what's going wrong, and you can fix it right away without any surprises. Again, here a CT scan to study it. The team of Guerrero, Dr. Guerrero, tried to classify, let's say, CT scan planning, and this is just a CT-based MAC score. The higher the score, the higher the risk, and you can see it here: high risk, high score, and high risk of embolization or migration of the valve. This is just pictures of the surgery, and what they do, you can see the MAC. All of this is calcification. They open it up, they debulk it, and they put a ring here. And this is the anterior valve, this is posterior valve. This is the stitches after they finish the debulking. All this is just to stabilize the valve. They tend to do other techniques like transatrial implantation. This is a surgical approach. They open the heart, but they use a balloon with the valve. And one of the surgeons who used to do that in the beginning, before starting the percutaneous approach, the talk was in 2011 or 13, I don't remember. He was talking a lot. He was talking about that there is a lot of risk because he tend to implant the valve, and within seconds it will there will be an embolization of the valve. So he was talking to the interventional cardiologist that this is not gonna happen. This is really difficult to stabilize the valve, and imagine all this while doing it percutaneously. But things have changed, and the teams all over the world have progressed. Now we can use percutaneous approach for either failed bioprosthesis, which means that like patient who had prosthetic valve degenerated over the years, you can do valve and valve. You can do valve and MAC, or for patient with dedicated devices where there is no mitral annular calcification. The challenges and the risks are either embolization, and this is very high. Paravalvular leak could be treated with a plug, and LVOT obstruction. For LVOT obstruction, it's fatal. So once it happened, it will obstruct the outflow of the LV outflow. This means from the LV to the aortic valve, and you will have a sudden cardiac arrest on table. So to plan for the this intervention, people tend to do a septal reduction strategies where they go to the left anterior descending artery, one of the septals. They will inject alcohol, and what happens is that they will induce myocardial infarction in a studied area in a very controlled manners. And this will reduce the LVOT septal thickness, and where will reduce the risk of LVOT obstruction. Other techniques are they pass the lampoon. They pass some device trans aortic and transatrial, and what they do is laceration of the anterior leaflet, and this after the laceration there will be less risk of LVT obstruction. Finally, the surgical resection. That's a direct way. I'll now move on. Mitral 2 trial. This is expected to be done by 2026 and published in 2030. They use Sapien 3 valve and Sapien 3 ultra valve. And those valves are used for aortic stenosis and TAVI. Well, the difference is when they load the valve on in the catheter, they load it in the opposite way, and they do a atrial puncture. So they move from the right atrium to the left atrium, and then they just go into the valve and implant it. So that's 100% transeptal, and they're following 100 patient versus natural history 100 patient. I'll see how it goes. Here they adapted a little bit where they will do good planning with alcohol septal ablation, lampoon, and they will go for implantation of the valve of the new LVOTs, which means the LVOT after implantation should be less than, more than 200. There are other dedicated devices. So what are most of people, even here in France, they use the Sapien. There is a dedicated device like the Tendyne. It has limited license here in France. I think 2 centers only have it, and it's a transapical implantation. So they pass from the apex to the valve and they implant it, and there will be a plug that will close the apex. It doesn't have a lot of good feedback, but some other there are trials that's going on here. Interpede, one of the devices that kind of famous. They're waiting for the approval of trials for that. No access in France. I think over Europe, yes, there are, but I'm not sure which centers. In the US, a lot. This is the Tendyne valve. Here, the angiogram after implantation. This is the transesophageal echo. This is the valve. This is the apical, let's say, plug. And it's in place, working. That's mitral annular calcification on CT scan, and you can see it. Can see it's grade, almost grade severe, grade 3, grade 4 mitral annular calcification, mostly on the posterior part, extending to the anterior part. And which is interesting is that they found that mitral annular calcification after doing a CT scan on a mummy. So what they did, there is a study where they did, I think, 30 or 33 mummies, and they basically did a CT scan. And one of the findings is that one of the mummies had mitral annular calcification. So we're talking about a disease that age more than 3,000 years old, I think, if I'm not mistaken. It's a pretty old disease. Thank you.
Thank you very much, Lucine. It was a very informative one. Very nice lesson, different from our usual interventional cardiology style lesson, which gave us a very different perspective and important perspective. We really appreciate. Thank you very much. And the
Thank
story
you.
of mommies was very interesting. Like such an
Yeah.
ancient disease. It was very interesting. Regarding the risk of embolization, you mentioned even with the recent technologies, this risk is still high. Can you ask how high is this risk and how you manage, how you plan to prevent this risk?
So personally, I don't have experience with with percutaneous and implantation of the mitral valve. I've seen it a couple of times in our center, and it was valve in ring, and usually valve, whether it's valve in ring or valve in biprosthetic valve, it kind of lower in risk in terms of embolization because of the stability of the ring itself, and you can easily size your valve based on the ring that was done before. So people who had mitral valve repair, let's say 10 years ago or 7 or whatever, and now we have a degenerative mitral valve after 7, 10 years, and he's symptomatic and he's not fit for surgery. So he was brought to the cath lab. It was fairly easily, even the planning, because there was no risk of LVOT obstruction. The only thing that they are talking about the stability of the valve. It won't be stable while implanting it because there is no anchoring calcium, let's say, all over the way, not like the aortic stenosis, where you are implanting the valve in a tubular structure. Here, it's a very dynamic structure. You're talking about diastole, systole, moving in and out. The valve itself, the mitral valve, changes its shape during diastole and systole. In systole, it is saddle shaped, and diastole, it is kind of flat. The LV itself, it will change in size and height. So we're talking about a lot of changes that happens during the systole and diastole in every contraction. So the risk is attributed to this. Uh, for the percentage of risk, I'll have to go back to my, because I think it's mentioned here, if I'm not mistaken. I don't have it in my head. Up, duh, 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 duh. I have to go back to you regarding this. Valve embolism, for example, here, but we cannot count on those cases because it's a
Yeah.
really highly high volumes centers. They do a lot, so you can't just count on that. But here it's estimated 4.3, 1.6, 6.9. I believe it's more.
Yeah.
So those are registry where people are doing a lot of cases like that. So I wouldn't count a lot on that.
Yeah, yeah, no, thank you very much for the complete explanation, and I totally agree with you. In real life, it should be, of course, higher than the studies